of the biggest challenges for me with bronchiectasis is understanding when I'm having an exacerbation, whether a difference in my sputum or a difference in my cough or shortness of breath or other symptom indicates something that needs a sputum culture that might need antibiotics. It still feels like a really grey area for me. And if I do put in a sputum culture to see whether I need antibiotics, it's not a very fast process, so it's quite difficult for the health system to work in the way that bronchiectasis patients need to be able to quickly send a sample in for testing and to get the result back in time to have the antibiotics prescribed if you need them.
Diagnosing an exacerbation of bronchiectasis is not easy. Guidelines say that it's mostly an increase in symptoms. So if your patient experiences a worsening of their symptoms over 2 or more days, that qualifies for an exacerbation. Patients rarely develop fever or an infiltrate on chest x-ray, so there's no point in referring patients exacerbating to a chest x-ray. Research tells us that bacterial infection is a chronic bacterial infection in people with bronchiectasis. So the bacteria in their airways are constant, whether at an exacerbation or at stable state. What really causes an exacerbation is currently unknown. We think it's an increase in the bacterial load or an increase in their virulence. In all but the mildest exacerbations, we do prescribe antibiotics because they have been shown to reduce symptoms and speed up recovery. We also instruct our patients to increase their airway clearance. And in all but the mildest exacerbations, we prescribe antibiotics for 10 to 14 days based on what we know the patients are culturing by previous cultures. We do send a new culture in just in case there are surprises, but if your patient does need an antibiotic, even though they don't grow anything, you should still prescribe the antibiotic course for a bad exacerbation.
So the other really important role for primary care teams is in making sure bronchiectasis patients have appropriate treatment for their exacerbations. In contrast with asthma and COPD, bronchiectasis patients typically get 10 to 14 days antibiotics, and this is usually based on a previous culture result if one's available, but it's always a good idea to send off a sputum culture at the start before you start antibiotics to help guide subsequent treatment for that exacerbation if treatment change is needed. Again, in contrast to asthma and COPD, we don't give oral steroid courses to patients with bronchiectasis because they don't work, they're not effective, and we'd be exposing patients to harm. If you have patients who are exacerbating frequently or their clinical course has changed and is deteriorating, perhaps they have now an increase in symptoms and a reduction in quality of life, then these are the patients that should be seen more promptly back in secondary care to try and work out what the cause of that is.